Your heart is not beaten at the same interval twice today. The gap between beats shifting by 10, 20, 30 milliseconds constantly without your awareness. The healthy heart is not steady, it is variable, and the degree of that variability is the single most reliable predictor of cardiac health that modern autonomic medicine has found. The nerve that controls it, a branch of the vagus called Arnold's nerve, surfaces through the cartilage of your outer ear, closer to the skin than at any other point on the body's surface. An oscillator behind your sternum can be reached, mechanically, through a flap of cartilage on the side of your head. A heart that beats at perfectly even intervals, same gap, same duration, same metronomic precision, is approaching failure. Cardiologists see it on the monitor and recognize it as one of the most ominous patterns in clinical medicine. An oscillator so locked into regularity that it has lost the capacity to adjust to anything. Healthy hearts scatter. Failing hearts keep perfect time. You have never noticed your own variability. No pulse at the wrist captures it. Only a monitor measuring the interval between beats to the millisecond reveals the pattern, and what it reveals is a scatter that would surprise most people who see their own data for the first time. Most people think of the heart as a pump. 4 chambers contracting in sequence, valves directing flow, blood pushed through 100,000 kilometers of vasculature at 5 liters per minute. That is the output. But before any chamber can contract, something has to set the timing to determine when each beat begins and how long the interval lasts before the next one. That something is the sinoatrial node, a cluster of roughly 10,000 specialized cells in the upper wall of the right atrium, smaller than a grain of rice. These cells do not wait for instructions from the brain. They do not need external input to fire. They generate their own electrical signal, roughly 70 to 80 times per minute, entirely from their own internal physics. An oscillator, a system that produces repeating electrical discharges at a frequency determined by the physics of its own membranes. Each cell in the node maintains a voltage difference across its membrane, negative inside relative to outside. But unlike most cells in your body, which hold that voltage steady until something disturbs it, sinoatrial cells do not hold. They leak. A peculiar set of ion channels, discovered in the 1970s and named the funny current because the researchers who found it could not believe a cardiac cell would behave this way, allows sodium and potassium ions to drift inward at rest. The voltage inside the cell creeps upward, slowly, steadily, without any external trigger, like water rising toward the rim of a basin with no one pouring. What made the current funny was its physics. Every other voltage-gated ion channel known at the time opened when the membrane grew more positive. Depolarization activated them. The funny current opened when the membrane grew more negative, after the previous beats reset. It activated precisely when every other channel shut down. The oscillation exists because this one channel type works backward relative to everything else in electrophysiology. Without it, the sinoatrial node would fire once and wait, like every other excitable cell in the body. With it, the node resets and climbs again automatically for a lifetime. During cardiac transplantation, every nerve connection to the heart is severed. Sympathetic, parasympathetic, everything. The transplanted heart receives zero neural input from the new body it occupies. It beats anyway because the funny current does not need nerves. The oscillator is self-contained. It fires from its own physics, roughly 100,000 times per day, whether the brain is connected or not. When the voltage reaches threshold, the cell fires. Calcium channels snap open, the voltage spikes to positive territory, the electrical signal propagates across the atrium, and the contraction begins. Then potassium channels open, the voltage crashes back down, the funny current reactivates, and the slow upward creep starts again. One complete cycle takes roughly 800 milliseconds. Then the next begins identically from the same internal physics. Every pulse you have ever felt at your wrist is the moment the funny current's slow climb reached threshold and the sinoatrial node fired. The pause between pulses is the climb itself, voltage creeping upward inside 10,000 cells the size of a grain of rice until the threshold trips and the next beat begins. That creeping phase, the slow diastolic depolarization, is what makes the sinoatrial node an oscillator rather than a switch. A switch waits to be flipped, an oscillator generates its own rhythm, and the frequency of that rhythm depends on one variable, the slope of the voltage climb. Steeper slope, faster firing, more beats per minute. Shallower slope, slower firing, fewer. But the slope changes constantly. Two systems reach the sinoatrial node and fight to control it. Sympathetic input, the accelerator, releases norepinephrine onto the sinoatrial cells. Norepinephrine increases the funny current. More ions leak inward. The voltage climbs faster. The threshold arrives sooner. Heart rate rises. This is what activates when you stand from a chair, when you hear an unexpected sound, when you start climbing stairs. The accelerator depresses and the oscillator speeds up. Parasympathetic input, the brake, releases acetylcholine through the vagus nerve onto those same cells. Acetylcholine does two things simultaneously. It reduces the funny current, slowing the voltage climb, and it opens additional potassium channels that pull the resting voltage lower, further from threshold, so the climb has more distance to cover. Both effects lengthen the interval between beats. The heart slows. These two inputs do not take turns. Both are active, continuously, pulling the oscillator in opposite directions, and the balance between them shifts with everything your body encounters. Every breath, every posture change, every fluctuation in blood pressure, every shift in attention. A sudden noise in a quiet room tips the balance toward the accelerator for 3 or 4 beats before the brake corrects. A long exhalation tips it the other way. The accelerator pushes slightly harder. The next beat arrives 12 milliseconds early. The brake pushes back. The following beat comes 19 milliseconds late. The beat after that, somewhere between. Stand up from a chair, and the physics becomes visible in the data. In the first second, before any conscious awareness of effort, the accelerator fires. The intervals shorten. Heart rate climbs by 10 to 15 beats per minute within 5 seconds, a remarkably rapid adjustment for a system most people assume operates slowly. Baroreceptors in the carotid artery detect the postural drop in pressure, and the brainstem adjusts the balance, more accelerator, less brake, to maintain perfusion to the brain. Then, over the next 30 seconds, the brake re-engages and the intervals lengthen again, settling toward a new equilibrium. The entire sequence, departure, adjustment, stabilization, is written in the beat-to-beat intervals. It happens without a single conscious thought. Lie down at night and the balance reverses. During deep sleep, the brake dominates. Heart rate drops. The intervals between beats lengthen and their variability changes character. Slower, wider oscillations that reflect parasympathetic dominance. A full night of sleep produces a heart rate variability profile so distinctive that researchers can identify sleep stages from the beat-to-beat intervals alone, without measuring brain waves or muscle activity. The oscillator broadcasts the state of its competing inputs, whether you are standing, sitting, sleeping, or running. If you have ever worn a fitness tracker that reports a resting heart rate each morning, you have been looking at the output of this oscillator, but only a crude summary of it. The resting rate is an average. It discards the variability between beats, the very information that carries the most clinical weight. Two people with identical resting heart rates of 68 beats per minute can have profoundly different beat-to-beat variability. One oscillator is being pulled broadly between competing inputs. The other is barely being pulled at all. This is why your heart rate varies. The oscillator is extraordinarily precise. The variation comes from two competing signals adjusting its frequency breath by breath, in response to conditions the oscillator alone cannot sense. Wide variability means both inputs are strong, responsive, capable of pushing the oscillator across a broad range. Narrow variability means one or both have weakened. Cardiologists quantify this with precision. Standard analysis takes the raw sequence of beat-to-beat intervals and decomposes it into frequency components. The same mathematical approach that allows engineers to separate a complex sound wave into its constituent frequencies. The result is a power spectrum, a graph showing how much variability exists at each frequency band. Your heartbeat's power spectrum contains distinct bands that correspond to different physiological oscillators. A high-frequency band, corresponding to oscillations that cycle roughly once every 2 to 7 seconds, driven almost entirely by the vagus nerve. The parasympathetic brake. When vagal input to the sinoatrial node is strong, high-frequency power is high. When vagal input weakens, that band flattens. This measurement, high-frequency heart rate variability power, is the most validated non-invasive marker of cardiac vagal tone in clinical medicine. A number you can track over months and years. And it tells a story about the brake that nothing else in routine clinical testing reveals. Reduced high-frequency power predicts cardiovascular mortality independently of every traditional risk factor, as Tucci and colleagues established in a 1996 analysis of the Framingham Heart Study cohort published in Circulation. Participants in the lowest quartile of high-frequency power had significantly elevated risk of cardiac events compared to those in the highest quartile, even after adjusting for age, smoking, diabetes, and left ventricular function. The oscillator's variability, measured from a simple chest strap monitor, carried predictive power that blood pressure and cholesterol levels alone could not match. You now understand what the oscillator does, why its output varies, and what the variation measures. The question changes from what produces the variability to what controls the brake. Because the brake is the input that matters most for long-term health, the one that declines most steeply with age, and the one with a physical fact attached to it that very few people ever learn. After exiting the skull through the jugular foramen, the vagus nerve's main trunk descends through the neck into the chest and abdomen, branching to the heart, lungs, stomach, intestines. For its entire descent, it runs deep, threaded behind the carotid artery, buried in tissue no fingertip could ever reach. But immediately after exiting the skull, before the main trunk begins its descent, a small branch splits off, the detour to the ear. Arnold's nerve reaches the outer ear through a channel barely 2 millimeters wide, called the mastoid canaliculus, delivering vagal sensory fibers to the tragus, the small cartilage flap directly in front of the ear canal opening, and to the concha, the bowl-shaped cavity of the outer ear. Between the thin skin of the tragus and the cartilage beneath it, Arnold's nerve fibers sit within millimeters of the surface. The tragus and the concha are the only locations on your entire external body where a branch of the vagus nerve can be reached without a needle, without surgery, without an implanted device. Vagal fiber density across the ear was mapped precisely. As Puker and Filler documented in Clinical Anatomy in 2002, confirming that the tragus and cymboconchae carry the densest vagal innervation on the external ear, while the earlobe carries none. The earlobe is supplied entirely by a cervical spinal nerve from the second and third vertebrae, with no vagal connection whatsoever. Every clinical trial testing auricular vagal stimulation uses the earlobe as its sham control for this reason. Identical tactile sensation, identical appearance, zero vagal activation. Why evolution routed a branch of the vagus nerve through the temporal bone to the outer ear remains unclear. No consensus. Anatomical explanation exists. What mattered to Friedrich Arnold, who described this branch in 1831, was its location. What matters to 21st century medicine is something Arnold could not have known: the physics of what happens when mechanical force is applied to the skin covering that nerve. Learning the proximity of that nerve changed something practical for me. My first experiment was pressing the tragus for 30 seconds with a chest strap monitor running. The vagal power reading moved, small but visible, within the first minute. The gesture has been daily since. Mechanoreceptors in the tragus skin are force-to-voltage converters. Each receptor is a specialized nerve ending enclosed in a deformable capsule, a structure whose geometry translates external pressure into membrane distortion. When force compresses the capsule, the physical deformation changes the shape of ion channel proteins embedded in the nerve membrane. Channels open, not through chemical signaling, not through a receptor binding event, but through mechanical strain on the protein structure itself. Ions flow through the open channels. The membrane depolarizes. When depolarization reaches threshold, an action potential fires and propagates along the nerve fiber. This is mechanotransduction, the direct conversion of force into voltage, and the sensitivity is extraordinary. Meissner's corpuscles in the tragus respond to forces as light as the weight of a single grain of sand resting on the skin. But for sustained pressure, Merkel cell endings are the relevant transducers. Merkel cells respond to maintained force with tonic firing, a continuous, unbroken stream of action potentials that persists for as long as the force is applied. More force produces a higher firing rate. The relationship is approximately linear within the physiological range. Double the pressure, roughly double the frequency. Force in, voltage out, proportionally. At the molecular level, the responsible ion channel has been identified. Piezo 2, named definitively in 2010, is a protein whose structure physically opens under membrane tension. When the lipid bilayer surrounding it deforms, the protein expands and the pore widens. Ions pass through. The elegance of the design is that no intermediate step exists. Force on the membrane becomes current through the channel in microseconds. No enzyme cascade, no second messenger, no amplification chain. Mechanical energy converts to electrical signal at the speed of protein conformational change, a fingertip pressing against cartilage, a protein changing shape in the nerve membrane beneath the skin, a channel opening because the membrane around it stretched. The entire conversion from pressure to electrical signal happens faster than you could notice the sensation of pressing. Well, the distinction between phasic and tonic responses matters. A brief tap on the tragus produces a burst of action potentials from the Meissner's corpuscles and then silence, the phasic response. Sustained compression produces continuous firing from the Merkel cells, the tonic response. Continuous tonic input to the brainstem generates a stronger and more sustained vagal reflex than a burst and silence pattern. The physics favors steady pressure, not tapping. When pressure compresses the tragus against its underlying cartilage, firm, sustained, enough to indent the skin a millimeter or two, the Merkel cells innervated by Arnold's nerve generate tonic firing. That continuous stream of action potentials travels through the temporal bone to the brainstem, arriving at the nucleus tractus solitarius, which processes all vagal sensory input, signals from the heart, signals from the baroreceptors, signals from the stretch receptors in the lungs. Tragal input arrives through a branch of the vagus, and the brainstem responds reflexively with increased parasympathetic output to the sinoatrial node. The brake presses harder. The oscillator slope shallows. The interval between beats lengthens. Variability increases. 3 neurons connected by fast-conducting myelinated fibers span the arc from tragus to brainstem to heart. Changes in heart rate variability become measurable within 30 to 90 seconds of sustained compression. The latency is short because the pathway is short and the fibers are fast. And then, the clinical measurements confirmed exactly what the physics predicted. High-frequency heart rate variability power increased during tragal stimulation compared to earlobe stimulation, as Badran and colleagues demonstrated in a 2018 study published in Brain Stimulation. With no vagal fibers, the earlobe produced no change, not a reduced change, but no measurable vagal response at all. The tragus produced a measurable shift in vagal tone within the first minute. The difference confirmed that the response was vagal, not placebo, not generalized relaxation, a conclusion only possible because the earlobe, with its complete absence of vagal fibers, provided an anatomically precise negative control. 2 centimeters of distance on the ear, one with vagal innervation and one without, produced entirely different brainstem responses. The anatomical specificity of the effect: vagal activation in the tragus, zero vagal activation in the earlobe, eliminated every alternative explanation except the nerve itself. Inflammatory cytokines, the signaling molecules that sustain chronic cardiovascular inflammation, decreased after repeated auricular stimulation sessions, as Lerman and colleagues confirmed in Bioelectronic Medicine in 2019. The vagus nerve suppresses inflammatory cytokine production through the cholinergic anti-inflammatory pathway, a direct link between brainstem parasympathetic output and immune cells in the spleen. Stronger vagal input produced measurably weaker inflammatory output. Atrial fibrillation burden decreased in patients receiving auricular vagal stimulation. As Stavrakis and colleagues reported in the Journal of the American College of Cardiology, Clinical Electrophysiology in 2020, the oscillator's rhythm, disrupted by fibrillation into chaotic firing, responded to increased parasympathetic input delivered through the surface of the ear. A cardiac arrhythmia modulated through an ear clip. Clinical devices deliver electrical current through small electrodes on the tragus. A fingertip on that cartilage delivers mechanical pressure. Electrical stimulation depolarizes nerve fibers directly, forcing the channels open with current. Mechanical pressure opens them through physical deformation. Different input modality, same nerve, same brainstem destination. One population for whom this reflex poses a genuine concern: anyone with an implanted pacemaker or cardiac defibrillator. The vagal reflex that slows the sinoatrial node can conflict with the device's programmed pacing algorithm, 2 signals reaching the oscillator with competing instructions. Anyone with an implanted cardiac device should discuss vagal stimulation with their cardiologist before applying sustained tragal pressure. Pressing the cartilage flap in front of your ear canal inward, index finger on the front, thumb supporting the back, compresses the tissue directly over Arnold's nerve fibers. The cartilage provides the rigid backstop. The skin provides the deformable layer. Arnold's nerve sits between them, Some people who compress the tragus firmly enough notice something unexpected, a tickle in the throat, or a brief urge to cough. Arnold's ear cough reflex, documented in clinical literature since the 1950s. Vagal afferents from the tragus share brainstem circuitry with the cough center in the medulla. The cough confirms that the brainstem is receiving vagal input from the ear and responding accordingly. Not everyone experiences it. Those who do are feeling the direct proof that Arnold's nerve is active. And then, the connection between the ear and the heart turns out to be only part of a larger coupled system. The vagus nerve also responds to breathing, and the physics of that interaction reveals something about resonance that connects the lungs, the heart, and the ear into a single oscillating circuit. When you inhale, your heart rate increases slightly. When you exhale, it decreases. This oscillation, respiratory sinus arrhythmia, has been documented for over 100 years, and it is generated entirely by the vagus nerve modulating the sinoatrial oscillator in synchrony with each breath. During inhalation, the brake releases, vagal output to the heart diminishes, the funny current steepens, the oscillator accelerates. During exhalation, the brake re-engages. Vagal output increases, the slope shallows, the oscillator slows. The oscillator slows. Every breath produces a corresponding cardiac oscillation. At normal breathing rates, 12 to 18 breaths per minute, the respiratory and cardiac oscillators interact loosely. The beat-to-beat fluctuation with each breath amounts to a few milliseconds, barely perceptible even on a monitor. But when breathing slows to approximately 6 breaths per minute, roughly a 5-second inhalation followed by a 5-second exhalation, something specific happens. The respiratory frequency enters the cardiac oscillator's natural resonant band, roughly 1 cycle every 10 seconds. Coupling between the two systems tightens. The amplitude of the heart rate oscillation increases by a factor of 4 to 5. The intervals between beats swing widely, accelerating markedly with each inhalation, decelerating markedly with each exhalation, and the high-frequency power measured in the vagal band rises substantially. This is resonance, the physics that shatters a wine glass driven at its natural frequency, that amplifies a child's swing when the push arrives at exactly the right interval, that causes a bridge to oscillate when footsteps synchronize with its period. The cardiac oscillator has a resonant frequency near 1 cycle every 10 seconds, and when breathing matches it, the two systems lock into tight phase coupling. The brake, driven at resonance, operates at its maximum possible amplitude. 6 breaths per minute corresponds to the frequency at which the coupled oscillator system produces maximal vagal output, a physical constant of the system, derived from the mechanics of the system itself. Consider what this means for the tragus. Arnold's nerve delivers a tonic vagal signal to the brainstem, steady, sustained, continuous for as long as the pressure holds. Slow breathing at 6 cycles per minute delivers a phasic vagal signal, oscillating, rhythmic, resonant. When both inputs arrive simultaneously, sustained tragal pressure during resonant frequency breathing, the brainstem receives vagal afferent activity through 2 independent channels at once. The tonic input supplements the baseline. The resonant input amplifies the oscillation. The combinatoric effect on the high-frequency band has not been measured in a controlled trial with this specific pairing. But the physics of superimposed inputs to a shared brainstem nucleus predicts summation. Heart rate variability does not remain constant across a lifetime. It declines, measurably, predictably, and for most people entirely without their awareness. Now, the decline follows a specific trajectory. High-frequency power drops by approximately 20 to 25% per decade in longitudinal studies tracking autonomic function. By 40, the high-frequency component has already fallen substantially from its peak in the 20s. By 50, many adults have lost half their peak vagal power without knowing it. By 70, it is a fraction of what it was. The parasympathetic input that created the beat-to-beat variability has diminished with each passing year, so slowly that no single morning feels different from the one before, the loss accumulating across decades without producing a single identifiable symptom. No routine physical measures. The decline. Your physician checks heart rate, blood pressure, cholesterol, blood glucose, none of which capture the state of the brake. A 65-year-old whose high-frequency power has dropped to the lowest quartile for age walks out of the consultation with normal vital signs and a weakening parasympathetic system that no one mentioned, because no one measured it. The decline does not feel like decline. It feels like nothing, which is precisely why it progresses unchecked through entire decades. And yet the declining rate predicts outcomes that blood work cannot. Cardiovascular mortality rises. All-cause mortality rises. The risk of developing atrial fibrillation increases. The anti-inflammatory pathway weakens in lockstep with the cardiac brake because both are outputs of a single vagal system losing signal strength. What this produces in the coupled oscillator is signal degradation. When one competing input weakens while the other remains relatively preserved, the oscillator loses complexity. The beat-to-beat variation narrows. The rhythm becomes more regular. Consequences extend beyond the cardiac oscillator. The cholinergic anti-inflammatory pathway, the vagal suppression of inflammatory cytokines, weakens alongside the cardiac brake when vagal tone declines. Chronic low-grade inflammation increases partly because the parasympathetic signal holding it in check has quietly faded. Each sustained press on the tragus activates the mechanotransduction arc, Arnold's nerve to brainstem to parasympathetic output, to the sinoatrial node, to the inflammatory pathway, to an oscillator that has been losing its brake for decades. A mechanical supplement to a system that has been losing endogenous drive. That distinction, supplementing a fading signal rather than reversing the decline, is why I record the high-frequency number each morning. Not to watch it climb. To confirm the brake still has force behind it. Arnold's nerve surfaced into your tragus cartilage before your lungs took their first breath. Every incidental contact since, every earphone adjustment, every absent-minded press while thinking, every pillow through the night, has sent action potentials to the brainstem and modulated an oscillator whose variability was never a flaw in the timing. It was the timing. Two competing systems adjusting to everything your body encounters, fading across decades through a nerve that surfaces in cartilage a fingertip can reach. The variability is the signal.